What if I told you aging isn't something that simply happens to you? It's something that accumulates, day by day, through tiny, ordinary habits that most of us barely notice. What separates two people both in their 70s can be a handful of small routines: how often they stand up, what shows up in their pillbox, whether they sleep in a regular rhythm, how much they drink during the day, and how they manage the quiet, persistent stress of later life. These are 5 dangerous habits seniors must break before it's too late. Not because you failed, but because these patterns quietly add up over years and then show up as falls, frailty, hospital stays, and slower recovery. I'm Dr. Emily Carter. I've spent more than 2 decades caring for older adults in clinics and hospitals, watching how small changes can tilt the balance between independence and dependence. My goal here is practical: to name the habits that matter, explain in plain language why they harm your body, and give you realistic, doable steps you can start using tomorrow. I won't promise miracles. I will tell you what research and clinical experience show, and I'll give you micro-actions you can try without dramatic upheaval. If you want weekly, evidence-informed tips to help protect your health as you age, consider subscribing and turning on notifications now. I'll keep these short, practical, and respectful of your time. Let's begin. First, sitting. Most of us think of it as rest, but prolonged sitting is not benign. If you spend long periods in a chair, TV, reading, computers, meals, your muscles stop doing the steady, low-level work they were built for. When leg and core muscles aren't activated regularly, several things happen. Blood flow slows, glucose control worsens because your muscles aren't taking up sugar efficiently, and the small daily stimulus that maintains muscle mass and balance disappears. Over months and years, this feeds frailty, increases the risk of falls, and is linked to higher mortality. Mechanically, standing and moving use the large muscles of the legs and hips. Those muscles help pump blood back to the heart and use glucose and fat for fuel. When you stay seated for long stretches, circulation becomes sluggish, and your body sends biochemical signals of disuse, hormones that favor fat storage, lower insulin sensitivity, and less bone-loading stimulus. For an older adult, that means losing muscle strength and balance, the very things that prevent a trip from turning into a fracture or a hospital visit. You don't need to run marathons to beat this. Small, frequent movement is the powerful piece. Stand up every 30 minutes, not as a one-off, but as a habit. Set a gentle alarm on a watch or phone, put a sticky note on the coffee table, or tie a simple visual cue, a bright coaster, a small plant, to remind you. When you stand, do a short, purposeful movement. March in place for 30-60 seconds, perform 3 sit-to-stand repetitions from your chair, or walk to the kitchen and back. Over the day, these micro-bouts of activity add up to improved balance, steadier blood sugar, and preserved strength. If mobility is limited, adapt the movement. Seated leg extensions, ankle pumps, and seated marches maintain circulation and stimulate muscles without standing. If pain makes movement scary, start with 2-minute sessions and increase slowly. The key is repetition and consistency. A 10-minute walk once a week won't offset 8 hours of sitting every day. Visualize it this way. Every time you stand, you send a message to your body that it still needs those muscles. It's not grand, it's persistent. Common questions I hear: won't standing so often make my joints sore? Possibly at first, but gentle, repeated activation helps lubricate joints and strengthens supporting muscles. What if I have balance issues? Use a sturdy chair or countertop for support. Work with a physical therapist to tailor safe standing exercises. The goal is to reduce uninterrupted sitting, not to create new risks. Second, the pill problem: medication accumulation or polypharmacy. Nearly 4 in 10 adults over 65 take 5 or more prescription medications. That statistic reflects how common multi-drug regimens have become. Blood pressure pills, diabetes medicines, sleep aids, pain meds, cholesterol drugs, and often a handful of over-the-counter supplements as well. Each medication has benefits, but with age the body handles drugs differently. Absorption, distribution, metabolism, and excretion all change. That shifts how drugs act and how they interact with one another. The result can be dizziness, confusion, falls, low sodium, or nutrient depletion, and studies have shown an association between higher medication counts and worse outcomes. In one study, taking 5 or more medications was linked to a 2.4 times higher risk of death. This doesn't mean pills are bad. Often they're essential. But it does mean we must treat medication lists the same way we treat a garden, weed, regularly. The practical step is simple and safe. Schedule an annual medication review with your clinician or pharmacist and bring a complete, updated list. Include prescriptions, over-the-counter drugs, vitamins, and herbal supplements. Ask these 3 questions when you review any medicine. Is this still necessary? Is the dose appropriate for my age and kidney function? Could this be interacting with my other medicines or causing side effects like dizziness or confusion? When you ask those questions, do so with curiosity, not confrontation. Many medications are started for good reasons and then linger. Sometimes a dose can be lowered, the timing adjusted, or a trial stop planned under medical supervision. Other times, a non-drug option like a physical therapy program for pain, sleep hygiene for insomnia, or a simple topical cream can reduce reliance on systemic medications. Pharmacists are especially useful here. They're experts in interactions and can flag combinations that increase fall risk or impair thinking. Barriers are real. You might live far from your clinic, have multiple specialists prescribing medicines independently, or worry that a doctor will be offended if you question a prescription. Overcome those barriers by centralizing your list. Keep a single printed copy in your wallet or on the fridge and bring it to every appointment. Ask your primary care clinician to do an annual med reconciliation and to coordinate changes with specialists. If travel or mobility is an issue, many pharmacies and clinics now offer telehealth medication reviews. Let me address a common worry. If I stop these medicines, won't my condition get worse? That's why medical supervision is essential. We do not stop or change medications on our own. The goal of a review is to identify medications that may no longer be necessary or may be doing more harm than good, and to make changes in a controlled, safe way. If you're prescribed a medication that makes you dizzy on standing, for example, lowering dose or switching the timing could reduce falls, but only under a clinician's guidance. Third, sleep. Not just how long you sleep, but the pattern and quality. Sleep is when the body repairs cells, clears metabolic waste from the brain, consolidates memory, and regulates hormones that affect appetite and inflammation. Both too little and too much sleep are linked to worse outcomes. A meta-analysis found that sleeping less than 7 hours was associated with a 14% increase in all-cause mortality, and sleeping more than 9 hours was associated with a 34% increase. Those numbers don't prove that sleep length alone causes death, but they do highlight that extreme deviations from a healthy sleep window often coexist with underlying problems. Untreated sleep apnea, chronic pain, mood disorders, or medication side effects that deserve attention. When I talk to patients, the most common sleep issues are irregular sleep times and fragmented sleep. Naps are common and can be restorative, but long daytime naps taken late in the afternoon can push bedtime later and reduce sleep depth at night. Bedroom lighting and evening screen time also matter. The brain's internal clock, the circadian rhythm, responds to light cues. Bright screens in the hour before bed can trick your brain into thinking it's daytime, delaying melatonin release and making it harder to fall asleep. The hygiene changes are not heroic. Choose a bedtime and wake time and stick to them, even on weekends. Dim the lights an hour before bed, move the phone out of the bedroom, or at least stop using it for 1 hour before sleep. Keep the bedroom cool, quiet, and as dark as possible. If you wake during the night, get up and do a quiet, non-stimulating activity until sleep pressure returns. Lying awake watching the clock often increases anxiety and makes sleep harder. If you struggle to fall asleep or stay asleep despite good habits, bring that up with your clinician. Some sleep problems benefit from behavioral approaches like cognitive behavioral therapy for insomnia, CBTI, which has strong evidence, especially for older adults. Be cautious with sedative hypnotic medications. They can increase fall risk and daytime confusion in older adults. Again, do not change prescription sleep aids without talking to your clinician. Where possible, explore non-drug strategies first. Now, a pause here to reflect. These first three habits, sitting, unchecked medications, and poor sleep, are tightly intertwined. Sitting less makes you sleep better and preserves muscle power to prevent falls. Reviewing medications can reveal drugs that interfere with sleep or balance. Improving sleep reduces daytime fatigue, which in turn reduces long periods of sitting. They aren't isolated problems. They form a web that either supports aging well or accelerates decline. Let me share a patient vignette to bring this web to life. I'll call him Mr. Thompson to protect his privacy. He was in his late 70s when he first came to my clinic after a minor fall at home. He'd been independent, living alone, and proud of his ability to manage. At the visit, his medications filled most of a page in the chart. Prescriptions for blood pressure, cholesterol, a sleeping pill he'd used for years, occasional pain medicine, and a daily supplement or two. He described waking 3 or 4 times at night, taking long daytime naps, and watching television for hours. He also reported a steady, creeping weakness in his legs. He didn't feel safe on stairs anymore. Over a few visits, we mapped the pattern rather than blaming him. The sleeping pill sedated him at night and left him groggy in the morning, increasing daytime napping. Long days in a chair reduced muscle use. Some of his medicines, when combined, contributed to dizziness on standing. He had mild dehydration most mornings because he didn't feel thirsty and avoided drinking much during the day so he wouldn't wake at night to use the bathroom. The fall itself was a close call. He tripped getting up from the couch after a long nap and turned his wrist. The injury required a short hospital stay and a few weeks of physical therapy to recover the balance and strength he'd lost gradually. This is not an unusual story. It's cumulative and subtle, but it's also reversible to a degree we often underestimate. With a coordinated plan, an annual medication review that reduced one sleep medication and adjusted blood pressure timing, a short, tailored standing and sit-to-stand routine to rebuild leg strength, and a sleep hygiene plan to reduce daytime napping. Mr. Thompson regained confidence. He didn't suddenly become 20 years younger. He did, however, reduce his day-to-day dizziness, nap less, and walk to the mailbox without thinking twice. Those practical gains meant fewer risks and more independence. What I want to emphasize is how small steps connect. Standing every 30 minutes sends a daily signal to preserve muscle. A medication review can remove blockers to steady balance and clearer thinking. A consistent sleep schedule reduces daytime fatigue and the urge to sit for long stretches. Each action supports the next. You may be thinking, that sounds fine for someone else, but I'm different. I have arthritis, I live alone, I have multiple specialists. Those are valid concerns, so let's tackle barriers with realistic solutions. For arthritis or joint pain, choose low-impact standing strategies, seated leg lifts, heel raises while holding a sturdy surface, or water-based exercise if you have access to a pool. If you live alone, use telemedicine or a phone call to set up a medication review, and ask a neighbor or a community volunteer if they can check in while you try new activity patterns. If specialists prescribe medicines independently, bring your complete medication list to every appointment and ask your primary clinician to coordinate a reconciliation. A short, practical toolkit you can use today. Set a timer to stand every 30 minutes. Print a current medication list and schedule an annual review. Pick a bedtime and wake time that you can stick with for at least 2 weeks. These are small investments of time for meaningful returns. Before we go deeper, let me answer a few common questions I hear in clinic. How do I know if my sleeping medication is the problem? Look for daytime drowsiness, morning grogginess, or an increase in naps. Mention these to your clinician. What if my doctor says I need all these medicines? That's an invitation to ask for a review focused on goals of care. What outcomes are we trying to achieve with each medicine? And is each medicine aligned with your current priorities? What if standing every 30 minutes is unrealistic? Start smaller. Aim for standing at least 5 times a day and build up. The habit is the target, more than perfection. We've covered 3 major habits already, enough to change the daily trajectory for many people. But 2 more dangerous habits remain: chronic underhydration and persistent low-grade stress. Both are deceptively common and often under-recognized. Thirst diminishes with age, and many older adults live regularly mildly dehydrated, which strains the kidneys, reduces cognitive clarity, and contributes to constipation and urinary problems. Chronic low-grade stress, the quiet worry about finances, health, loss, and independence, elevates cortisol over months and years, promoting inflammation, higher blood sugar, and muscle breakdown. Addressing those habits requires a slightly different approach because they are both behavioral and social. Hydration isn't just about drinking water, it's about routine and accessibility. Stress reduction isn't about eliminating worries, it's about building predictable practices that reduce the physiological impact of those worries. I'll be specific and practical in the next segment. Simple hydration routines that are appropriate for older adults with common medical conditions, and short, evidence-backed stress tools you can try even if you have limited mobility. I'll also lay out 3 nutrition strategies: the Mediterranean-style approach, even protein distribution, and hydration-supportive eating, that pull many of these threads together. But before we move to solutions that tie everything into a weekly plan, there's one more thing I want to emphasize: safety. You must not stop or change prescription medications without talking to your clinician or pharmacist. If you have heart failure, kidney disease, or a complex medical regimen that limits fluid intake, fluid advice needs to be individualized. If you're on blood pressure medicines that can cause dizziness on standing, addressing that through a med review is the right first step. Small changes are powerful only when they're safe and tailored. With that safety note in mind, think now about what you can do tomorrow morning. Pick one item, stand up every 30 minutes for 2-minute movement breaks, or print and carry your medication list for your next appointment, or set a bedtime that you can maintain for a week. Try one for a week and notice how you feel. Small, consistent steps are how real change begins. In the next section, I'll walk through hydration strategies and stress practices in detail, then show you the nutrition plan that can amplify the benefits of movement, sleep, and medication safety. I'll give concrete meal examples, portion guides for protein, and simple recipes that are both tasty and realistic. We'll also return to Mr. Thompson's story to see which small shifts made the biggest difference over months, and how to troubleshoot common barriers like low appetite, limited mobility, or living alone. For now, keep in your mind that aging is not a single, inevitable path. It's the result of hundreds of small choices, many of them automatic, and by making a handful of those choices differently, you can change the course. Next, hydration, and why a single glass of water in the morning matters more than you might think. Thirst perception blunts with age. That's a normal physiologic change. The body's alarm for drink doesn't ring as loudly as it once did. Add to that the common habit of avoiding fluids because of nighttime bathroom trips, and you have a steady state of mild underhydration. That mild dehydration isn't dramatic like heat stroke, but over weeks and months, it changes blood volume, kidney perfusion, and even the chemistry of the brain. Dehydration thickens the blood slightly, makes kidneys work harder, can worsen constipation, and reduces the bounce in joints and tissues that helps us move safely. Cognition dulls a little, balance may be less steady, and recovery from illness becomes slower. Start with a very small, very practical rule. Drink 1 glass of water right after you wake up. Keep it by your bedside or on your nightstand. The morning glass is a simple habit that rehydrates after 8 hours without fluids and gives your body a gentle signal that water is arriving on a regular schedule. From there, build a visible routine. Keep a 16-20-ounce bottle within sight when you're sitting in your favorite chair. Put a glass beside your chair and refill it every hour. Use a mug you like. Familiarity increases use. If you live with limited mobility, place a bottle on a rolling tray or use a cup with a straw that's easier to handle. Hydration-supportive foods are another cornerstone. Soups, especially broth-based ones, are hydration powerhouses. Fruit like watermelon, oranges, and cantaloupe are both hydrating and nutrient-dense. Cucumbers, tomatoes, and plain yogurt add water and electrolytes. If swallowing or chewing is a problem, smoothies made with milk or yogurt and fruit can be a nutritious, hydrating option. For many older adults, fluid needs can be met in part through these foods, which also make keeping fluids down easier for those who feel full quickly. A simple urine color check is an easy self-monitor. Aim for pale straw color. Very dark urine suggests you need more fluids. Very pale to clear may mean you're drinking more than required for your condition, but usually pale straw is a safe target for most. If you have heart failure, kidney disease, or any reason you've been told to restrict fluids, follow your clinician's plan. These conditions require individualized advice. Practical micro rules you can adopt now. Glass of water on waking, a small bottle on your main seating area, and sip regularly. Include 1 broth-based soup or a hydrating fruit daily. If you wake at night and feel the need to urinate, consider whether you've been avoiding fluids all day. A modest redistribution of fluids earlier in the day, plus timed evening limits, often works better than severe overall restriction. And, as always, check with your clinician if you have medical reasons to limit fluids. Next, stress. The quiet, persistent kind that doesn't look dramatic, but that wears you down from the inside. Chronic low-grade stress is common after retirement, illness, or loss. It's the background tension, worrying about bills, about driving, about whether your body will betray you. Unlike an acute crisis, this stress becomes a constant hum, and that hum raises cortisol chronically. Elevated cortisol over months and years shifts metabolism toward higher blood sugar, higher blood pressure, more inflammation, and even muscle breakdown. In older adults, that matters because we're trying to preserve muscle, bone, and immune resilience. The good news is that small, predictable practices markedly reduce the physiological cost of stress. You don't need to meditate for an hour to gain benefit. The single most useful micro-tool I prescribe is the 2-minute regulated breathing exercise. It's simple. Sit comfortably. Inhale slowly for 4 counts. Hold for 1 or 2 counts if that feels okay. Exhale slowly for 6 counts. Repeat for 2 minutes. 2 minutes. That amount of slow, regular breathing engages the parasympathetic nervous system, the rest and digest side, and lowers heart rate and cortisol spikes. Do it in the morning, before a nap, or before a stressful call. Movement is also a stress antidote. A 10-minute outdoor walk does more than burn calories. It changes your neurochemistry, lowers perceived stress, and exposes you to daylight, which helps sleep cycles. Social connection, a phone call with a friend or a brief coffee with a neighbor, reduces loneliness, which is a major amplifier of stress. Hobbies that absorb attention, reading a novel, tending a small garden, listening to music, are not frivolous. They are protective practices that divert the brain from rumination. Practical micro-actions include a 2-minute breathing practice twice a day, a 10-minute outdoor walk or 10 minutes of seated Tai Chi or gentle stretching, a scheduled social interaction, a phone call or a small group class at least twice a week. If worry feels overwhelming and persistent, reach out to a clinician. Anxiety and depression are treatable at any age, and there are behavioral and pharmacologic options that are safe when managed carefully. How hydration and stress tie into the other habits matters. Dehydration worsens mood and attention, which amplifies stress. Stress fragments sleep, and fragmented sleep increases the tendency to sit and nap during the day. The 5 dangerous habits: sitting, polypharmacy, poor sleep, underhydration, and chronic stress form a loop. Break one link and the whole system loosens. Now let's move to the 3 nutrition strategies that pull many of these threads together. These are not fad diets. They are practical patterns that support muscle, cognition, hydration, and cardiovascular health. They are Mediterranean-style eating, even protein distribution across meals, and hydration-supportive food choices. The Mediterranean-style pattern is about emphasis, not strict rules. It favors vegetables at every meal, whole grains, legumes, nuts, fish, and seafood several times per week, olive oil instead of butter, and modest portions of dairy and lean poultry. Red meat is eaten rarely and in small portions. This pattern is associated with better cardiovascular health, better cognition in aging populations, and improved glycemic control. For practical swaps, use olive oil for cooking and dressing instead of butter. Add a cup of mixed vegetables to lunch and dinner. Choose salmon, sardines, or mackerel twice a week for their omega-3 benefits. A very simple plate is half vegetables, raw or cooked, 1/4 whole grain or starchy vegetable, brown rice, sweet potato, and 1/4 protein, fish, poultry, legumes. Here are easy meal templates. Breakfast: Greek yogurt with a handful of berries, a sprinkle of nuts, and a small spoon of olive oil, if you like savory, or an omelette with spinach and whole grain toast. Lunch: a big salad with chickpeas, cherry tomatoes, cucumber, a small piece of grilled fish, and a drizzle of olive oil vinegar. Dinner: a bowl of vegetable-rich soup with chunks of white beans or lentils and a side of whole grain bread. Snacks: a piece of fruit and a small handful of walnuts, or a slice of whole grain toast with avocado. Even protein distribution is the second strategy, and it's essential for preserving muscle mass as we age. Research and clinical guidance suggest aiming for roughly 25 to 30 grams of protein at each main meal for many older adults to optimally stimulate muscle protein synthesis. That doesn't mean huge steaks. It means choosing protein at breakfast, not just at dinner. Breakfast examples: 2 large eggs plus a slice of whole grain toast and a small Greek yogurt. Together they reach that 25-30 gram target. If eggs don't suit you, try 6 ounces, about 170 grams, of Greek yogurt with a tablespoon of nut butter and a small scoop of protein-rich granola. Lunch examples: a can of tuna in water on whole grain crackers with a side of mixed vegetables, or a turkey and avocado sandwich with a cup of lentil soup. Dinner: a palm-sized portion of salmon or chicken with a large vegetable side and a cup of quinoa or beans. Don't forget snacks as opportunities. A small smoothie with milk or fortified plant milk, Greek yogurt, and a scoop of protein powder provides 15 to 20 grams quickly for those who have poor appetite. Cottage cheese, a handful of almonds, or a small can of salmon on crackers are portable protein options. For those with chewing or dental issues, softer options like mashed beans, scrambled eggs, and yogurt are helpful. The third strategy is hydration-supportive eating. I've already mentioned soups and watery fruits. Plan 1 soup-based meal daily, especially in winter. Vegetable broth with soft vegetables and white beans is easy to prepare and very hydrating. Add fruit to breakfast and consider an afternoon snack of melon or orange. Incorporate vegetables with high water content, cucumbers, zucchini, tomatoes, as side dishes or in salads. If dentition is a problem, smoothies made with milk or yogurt, frozen fruit, and a spoonful of nut butter supply protein and fluids together. Now, how do you translate all that into a week that's realistic? Start small and specific. Tomorrow, stand up every 30 minutes for 2 minutes. Have a 16-ounce bottle of water visible in your main sitting area. Include at least 20-25 grams of protein at breakfast. Do a 2-minute breathing exercise mid-morning and review your medication list and plan a call with your pharmacist or primary care clinician to schedule a medication review. That list may feel long, but each item is a micro-habit that's achievable. Pick 1 or 2 to start and add another after a week. Let's return to Mr. Thompson and follow through with the specific, realistic plan that helped him, because concrete examples are what translate knowledge into habit. When we revisited his case, the first step was medication reconciliation with his pharmacist and primary clinician. Under supervision, we tapered the long-standing sleep medication that left him groggy in the morning and shifted the timing of a blood pressure medicine that had contributed to orthostatic dizziness. Importantly, changes were gradual and planned, with monitoring calls scheduled. We never abruptly stopped anything. Next, his physical therapist taught him a set of 3 sit-to-stand progressions and a short standing balance routine that he could do 3 times a day. Those sessions were brief, 5 minutes total, but consistent. He began taking a short walk to the mailbox twice daily. We also addressed hydration and diet. He started having a small broth-based soup with lunch and a cup of Greek yogurt at breakfast. His caregiver put a water bottle on his table within reach and refilled it mid-morning and mid-afternoon. He adopted a consistent bedtime, putting his phone in a kitchen drawer an hour before bed and reading a book under a dim lamp. For stress, he committed to 2 minutes of breathing in the morning and another 2 minutes after lunch. Over 3 months, he reported measurable changes: fewer daytime naps, less morning dizziness, a small but steady increase in leg strength, and greater confidence walking outside. He did have a minor setback, a spell of viral gastroenteritis that caused fluid loss, but because he and his family had a hydration plan, he recovered without hospitalization. The key lessons from his story are practical. Medication review should be regular and coordinated. Movement must be frequent and tailored. Hydration and protein need planning. Sleep hygiene requires behavioral changes, and stress control can be achieved with tiny, repeatable practices. None of these steps are dramatic. Each is modest. Their power is cumulative. Now, a concrete 10-point action plan that you can use as a checklist. Consider printing this and putting it on your fridge or keeping it with your medication list. 1. Stand up for 2 minutes every 30 minutes while awake. Set a gentle alarm or use visual cues. If standing is difficult, do seated leg lifts and ankle pumps at the same cadence. 2. Glass of water on waking and a visible bottle in your main sitting area. Aim to sip every 20 to 30 minutes rather than chugging large amounts. 3. Protein at breakfast. Aim for 25 to 30 grams. Examples: 2 scrambled eggs plus Greek yogurt, or a smoothie with milk yogurt and a scoop of protein powder. 4. Schedule an annual medication review with your primary clinician or pharmacist. Bring a single printed list of prescriptions, over-the-counter drugs, and supplements to every appointment. 5. Choose a consistent bedtime and wake time. Dim lights and remove screens 1 hour before bed. If sleep problems persist, ask about CBTI or other non-drug options. 6. 2-minute breathing practice twice daily. Inhale slowly, exhale longer. Repeat for 2 full minutes. 7. Add 1 Mediterranean-style meal today. A bowl of vegetable soup with a portion of beans or fish. Use olive oil and a side salad. 8. Include 1 hydrating food daily: melon, orange, cucumber, tomato, or broth-based soup. 9. Build a short daily balance, strength routine. 3 sets of sit-to-stands, ankle pumps, and 2 brief walks or mobility sessions. Increase slowly and celebrate consistency. 10. Create a backup plan and supports. Identify one person who can check in, friend, neighbor, caregiver. Schedule telehealth for medication or mental health concerns, and locate local resources like senior centers, meal delivery, or home health if needed. Barriers and quick solutions. If arthritis or joint pain limits standing, start seated. Knee extensions and heel raises provide muscular stimulus without weight bearing. If appetite is low, choose nutrient-dense, smaller portioned foods, smoothies, fortified puddings, or compact snacks like nut butter on whole grain crackers. If you live alone and worry about managing changes, use telehealth for medication reviews and ask your clinic about community nursing or pharmacy outreach programs. If you have denture issues, soft proteins like cottage cheese, flaked fish, eggs, and well-cooked legumes are good options. If finances limit food choices, canned beans, frozen vegetables and eggs are affordable protein and nutrient-rich staples that fit a Mediterranean pattern when combined appropriately. Common questions I hear in clinic, and brief answers. What if I can't sleep more than 6 hours? First, ask whether your sleep times are regular and whether medications or sleep apnea might be interfering. Short sleep can be okay for some, but if you're fragmented, sleepy during the day, or have cognitive concerns, bring it up with your clinician. Behavioral options like sleep scheduling and CBTI often help. What if my doctor prescribes several medicines and won't change them? Ask for a goals-focused medication review. What is the intended benefit of each medication? How does it match your priorities? And can alternatives or timing changes reduce side effects? Most clinicians appreciate a patient who wants to align medications with life goals, especially when the conversation is framed collaboratively. How much water is enough? There's no single universal number because needs vary by weight, temperature, activity, and medical conditions. For many older adults, aiming for a visible bottle, 16-20 ounces, refilled several times a day, and a morning glass is practical. Use urine color as a guide, and always follow individualized clinical advice if you've been told to limit fluids. What if I can't do protein at breakfast because I have no appetite then? Start small. A Greek yogurt, a small cottage cheese cup, or a smoothie are gentle options. Protein powder mixed into oatmeal or a smoothie can provide a concentrated boost without a large volume of food. An important final safety note that I will repeat plainly: do not stop, start, or change prescription medications on your own. Medication changes must be planned with a clinician or pharmacist who understands your overall health, kidney function, and goals of care. If you have heart failure, end-stage kidney disease, or a condition that restricts fluids, consult your clinician before making hydration changes. If you are at risk of falls when standing, begin balance and standing exercises with support or with physical therapy guidance. We can summarize the pathway forward in a simple sentence: small, consistent signals matter more than sporadic effort. Standing frequently, regular medication reviews, consistent sleep, visible hydration routines, and daily stress micro-practices are the 5 levers you can pull to change the trajectory. Before we close, a brief encouragement about expectations. Change rarely looks spectacular in the first week. What you will notice, often over several weeks, is smoother mornings, fewer dizzy moments, better tolerance for walking, improved appetite, and sometimes small but meaningful improvements in mood and confidence. Those are real outcomes. You don't need perfection. Aim for persistence. If one last practical tip is helpful, pick 2 habits to start and pair them with existing routines. For example, stand for 2 minutes at every TV commercial break and have a glass of water when you return to the chair. Or do your 2-minute breathing exercise right after brushing your teeth in the morning and again after lunch. Tying new habits to old ones makes them stick. If this video helped you, please like and share it with someone who might benefit, a neighbor, a family member, or a friend. If you try one of the actions and it works for you, tell us in the comments where you're watching from and which micro-habit you picked. Hearing others' experiences helps the whole community. And again, consult your clinician or pharmacist before making medication changes, or if you have medical conditions that affect fluid or activity recommendations. Thank you for spending this time thinking about habits that really matter. Small, steady actions shape how we live in our later years. They don't promise miracles, but they do promise a better chance at staying independent, safe, and engaged. I'm Dr. Emily Carter. Be well, take one small step tomorrow, and I'll see you in the next video.